deliveries happen in the morning or the planned cesarean, and when we get a call from our referral obstetrician at an unexpected time, the first thing that comes in our mind that something has come out in the ultrasound we have done during the antenatal period. The same happened to me yesterday when Sharda ma'am called me. I thought that some obese patient, there was some VSD that is seen after the birth or so. So this kind of fear that we live in our day-to-day life, the fear of litigations, and this litigations happens mostly because of the congenital anomalies. So we have to be an idea of that what actually missed and what is not missed, and what should be missed and what can't be missed. So that is why this meeting is is all about. Our social media friends, our press, and our NGOs, it they take a pride in publishing this kind of news, like 1.25 crores compensation. If you go in a very sensitive way, what is 1.25 crore? 1.25 crore might be a life saving of one person, and what he or she is paralyzed for. He or she is paralyzed for doing their work. There is no mal uh, mal uh, 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 say there is no intention, there is no mal intention to do this purposely, but this has happened, and what they have to pay 1.25 crore as a compensation. Even in this case, that was very famously put in all the non-medical social media groups, also Facebook, also Instagram. Medical board clearly said that the childhood anomalies would be classified as limb reduction deficiency, and was also of opinion that the limb reduction anomalies can be detected in standard obstetric ultrasound, but the detection rate is low. So that was the board opinion of AIMS in that particular case. So I will take you through in this my talk that what is the detection rate in other countries, how we should make this court understand that what we can do and what we can't do. So what the our popular concept is, the popular belief is that only there is one anomaly scan exist in whole of the pregnancy, that is our 18 to 22 weeks scan or 18 to 20 weeks scan. Recently few of the more wiser people have understood that we can detect those defects even between the 11 to 14 weeks scan. But what our judiciary think? Our judiciary think that every ultrasound is an anomaly evaluation scan. But this is not just the dark side. This is a flip side also. So if there is an scope of detection of anomaly in every ultrasound, even after mid-trimester anomaly scan, so why not we take this into our account for our advantage? Reason being that if you see this kind of defects that we see in the latter part of the pregnancy by seeing a double bubble sign, that is dural atresia. So at that circumstances we can make the patient understand that look, it is not seen in our 18 to 20 weeks scan, because as the literature says, I am putting the cover book of our Bible, that is Ultrasound of Congenital Fetal Anomaly by Dario Palladini, that says that diagnosis of duodenal atresia is based upon the recognition of the classic double bubble, which is associated with polyhydramnios, which often develops in the late second and early third trimester. And usually when the mid trimester anomaly scan is carried out at 19 to 21 weeks of gestation in most of the countries, polyhydramnios is absent and the double bubble has not yet completely developed. So we have to make the patient, we have to make the judiciary understand that there are many anomalies, though those can't be detected in 18 to 20 weeks scan. So these are late appearance anomalies, and we should not put blame upon others that it is why it is not detected in the typical our 18 to 20 weeks scan. So this was the paper published in 2020 by the Kipros group only, and that concluded that a high proportion of the fetal abnormalities are detected for the first time during a routine ultrasound examination at 35 to 37 week of gestation, and such diagnosis and subsequent management, including selection of timing, place for the delivery, and postnatal investigation, could potentially improve the postnatal outcome. So in that case, we have to make the judiciary understand, the patient understand that look, this was not mean to be diagnosed at 18 to 20 weeks, and it is the best thing that it has been diagnosed at least at 35 to 37 weeks scan or the 30 to 32 weeks scan. Reason being that in this situation we can at least plan for the timing and the place of the delivery and the postnatal investigations. Similarly, recently we have a published practice guideline for the performance of the third trimester obstetric ultrasound scan also by the Asma Khalil group, and it also include besides other thing that the fetal anatomy. So it has included fetal anatomy because many of the fetal congenital malformations appear later part of the pregnancies. So, what are the common anomalies? Those are detected in the second and third trimester. So, most common abnormality, those are detected in the 35 to 36 weeks scan or 37 weeks scan, are the hydronephrosis, VSD, that is ventricular septal defect, mild ventriculomegaly, duplex kidney, ovarian cyst, and arachnoid cyst. Anomalies, those are exclusively only detected at 35 to 37 weeks, are the ovarian cyst, microcephaly, achondroplasia, dacrocystocele, and the hematocolpus. So as we are seeing here, that is, there is a large proportion of the congenital defect. Those are detected only at 35 to 37 weeks, and they are seen first time at that time. So we should not penalize or we should not blame somebody that why it is not detected in the earlier part of the pregnancies. Skeletal dysplasia is something that is almost always detected after 26, 27 weeks only. And whenever it is detected early, they are more of the lethal skeletal dysplasias. Amniotic band syndrome is one of the important cause of the litigation in the ultrasound, and it actually forms with the early rupture of the membrane, that is a fibrous band adhere and entrap to the fetus, and they can cause limb amputation and deformities, encephalocele and facial clefts, ventral wall defect, ectopia cordis. That is also like the amniotic states. It does actually, there is an auto amputation and the limb reduction defect. So this is why it is imperative that whenever we see both the hands and both the legs, we should always document it in our report with the films as well as with the cine. Because if you have seen after birth postnatally, there is a missing part of the limb. So at least you can say that at the time of the diagnosis, at the time of these assessment of the limbs, you have seen both the hands and both the limbs together. So most of the time we see the litigation because of the limb reduction defects also. Like in this case, where we have prior seen both the hands and both the legs, and the same patient when came referred to us in 35, 37 weeks. So we see that one of the limb were amputated. We also seen few of the fibrous bands there. Those are amniotic bands. So that was actually limb reduction defects itself. Polydactyly is not harmful, but many times it is also a topic of controversy that why it is detected postnatally. So it is important because sometimes they are syndromic and they are associated with a skeletal dysplasia as well. They are post-axial, that is 6 digit, that is on the ulnar side or the fibular side, or the pre-axial, that is a bit rare, that is in the additional digit, that is located on the radial or the tibial side before the thumb or the toes. So why are few of the anomalies detected only in the late second and third trimester? Why they are not detected early? Because they are incidental or accidental detection of the anomalies. There are second opportunity and they are truly missed abnormalities, evolving anatomical structures or the late onset. There are progression of a suspected anomalies, like if you are seeing there is only mildly prominent bilateral ventricles, and later on they become full-fledged ventriculo or beginning later on. There are regression of an abnormality as well, late infection or inserts or hemorrhage that can lead to the congenital anomalies, and there are cases of malrotations as well. So these are the main reason that why we are detecting few of the congenital defect in the late second and the third trimester. But there are few defects. Those are diagnosed only postnatally. We can't diagnose them prenatally, and they are isolated cleft palate, polydactyly many times, syndactyly, and ambiguous genitalia, that is hypoasparagus. One of the more interesting cases that one of us see in our long practice many times, that one of the baby now has grown to 6 or 7 years of age, and they have undergone ultrasound for some other reason, and they have found a single kidney. Suddenly you get a call that why there was a single kidney, because you have, when you did the ultrasound, there were bilateral kidney. So how that is single kidney? So there is two reasons. First is that most cases of the unilateral renal agenesis escape prenatal diagnosis because the bladder and amount of the amniotic fluids are normal, and so there are no indirect signs raising the suspicions of the renal disease. Moreover, in the same way as that of the bilateral agenesis, the presence of the adrenal gland in the ipsilateral renal fossa, they may resemble kidney. Many of you argue, no, color Doppler can detect the single kidney. Yes, I totally agree with you. But there are many cases in which the ipsilateral adrenal artery, they become so prominent, they actually resemble the contralateral renal artery. So they may escape the single kidney. There are also instances that has been reported in the literature in which one of the kidney were slightly smaller, and there was not absent. There are actually dysgenesis, and by the time they they have uh, they have uh, they have further atrophied, they become not detectable postnatally. So there are both the things. Those are actually reported in the literature as such. Cardiac defects are also one of the reason of the litigation in the ultrasound. The reason being that there is a high incidence of the cardiac defect. They are also associated with the non-cardiac and the chromosomal anomalies. There is increased neonatal and the childhood morbidity and mortality associated with the cardiac defect. But the good thing is positive impact of the prenatal diagnosis in the postnatal management of the cardiac defect is there. Like the appropriate timing of the surgical repair that we can plan. There is shorter ICU stay if we can detect it earlier. Decision of the delivery route, referral to the tertiary center, and requirement of the urgent postnatal intervention. But but I should emphasize here that there are many cardiac defects. Those are not detected prenatally, like the evolving anomalies. Evolving anomalies means, like, most common are the hypoplastic left heart syndrome. You might have detected and documented a normal heart at the time of the fetal echocardiography as well as 18 to 20 weeks scan. You see the same patient in your 30 weeks scan, and you see that one of the ventricle and the one side of the cardiac chamber are small. So they are hypoplastic left heart syndrome. Aortic valve stenosis almost always detect, lateral or not always. PVC, that is total anomalous pulmonary venous connections, is a diagnosis that is worldwide, has a maximum detection rate as a 12%. We all are working very hard, teaching very hard to make it better, but the cruel reality is that in the best of the center of the world, it is just 11 to 12% only. Rhabdomyoma, that is the cardiac tumor, that has a mean gestation age of detection is 28 weeks. It can't detect early, so we should not blame somebody that why they have not diagnosed it a bit earlier. So, if we see the ISWOG practice guideline of fetal cardiac screening that was published as late as 2023, so that clearly says that, however, prenatal detection rate vary widely in the different geographic region and for various type of CSD, with fewer than only half of the cardiac anomalies being identified before, only 50%. Some variation can be attributed to the differences in the examiner availability, of course, but transducer frequency, different machine settings, patient body habitus, abdominal scars, gestation age, amniotic fluid volume, and the fetal position also. There are two things. The first is the cardiac defect; those are more common, and another is a Down syndrome. That's an incidence of 1:900 in our population, very common, and they are also one of the cause of the litigations. So why this is important? Because they are very common. They have longevity. Every time you bring it to the judge or the court, they always get a sympathy that how this parent can brought up this child. And but it has a very subtle ultrasound finding. So where the ultrasound falls as far as the trisomy 21 detection is concerned. So if we take the again the literature and the textbook, so from the postnatal and prenatal data, it is evident that only 50% of the individual with Down syndrome do not show any major or minor anomaly possibly detected in utero. So Down syndrome has only 50% detection by the ultrasound. That is why ultrasound is not a good screening tool as far as trisomy 21 is concerned. And as 50% of the detection rate is concerned, this possibility can be taken by even the flipping of the coin. So either it is head or it is tail. So where we stand as far as world is concerned. So if you've gone through all the literature, different part of the world, right from the Sweden to England to Egypt to African countries. So detection rate with few of them are very good, like the anencephaly, 98%, open spina bifida, 90%. But there are some, those are poor, like the diaphragmatic hernia, it is 60%. Serious cardiac abnormality, it is hardly 50%. So we have to be a bit considerate that where we fall. So several organizations have attempted to make the purpose of the scan more focused by identifying the main structure to be assessed. So first we make the patient understand, judiciary understand that look, ultrasound is a screening for congenital anomalies. Screening means that screening has always a chance of false positive. That is where the disease is there but that might not be, and false negative, that it might be a low risk but it disease might be there. So we have to stop saying that it is normal. We have to say that there is no obvious congenital abnormality at the time of the detection, because like other screening, it has both the chances of false positive as well as the false negative. And if possible we have to make the patient understand that it is a low risk scan, so it is a low risk screening for the congenital abnormality. It is understood that there are other conditions that may be detected using the ultrasound screening tool, but because there are insufficient data to accurately predict the standard to which it can be achieved. So what is the standard? So in the Africa, it was 16.7%. In the South America, it was 34.3%. In Asia, it was 34.7%. And in Europe, that is less than 50%. That is 47.3% only. So that is how we are here to discuss that this is the world data. While another study on sensitivity of routine ultrasound examination for the detection of the abnormal chromosome and structural malformation in fetuses in second trimester in a non-selected population from Sweden. Sweden is considered to be a developed country. Reported a sensitivity for prenatal detection before 22 weeks of gestation is only 40.3%. So it is less than 50%. So the prenatal detection rate of chromosome abnormality was 60.7%, and the structural malformation was only 39.0%. So that was the data of a developed country where a person can do hardly 10 scans in a day, when in our lovely country we are doing, or in our government setup they are doing more than 100 scans in a day. So what kind of sensitivity are you expecting? They concluded that in a routine clinical setting in a country hospital with non-selected population, only half of the major structural malformation in chromosomally normal fetuses are detected by the routine ultrasound examination in the second trimester. So that is why it is less than 50% if we take the ultrasound screening for the congenital anomalies in account. So what we need to do, that was the problem. Now we have to look for the solutions. Solutions is that we have to describe our limitations, and we should describe it in detail, fearlessly, and without thinking that we will be judged. We should say that, look, you are 200 kg, your abdomen is too thick, and I'm not seeing anything, and whatever I will write, that will be my pure imagination. You should think that. You should also refuse this patient where you feel like that there is a limitation, and you should ask them to come after 2 weeks or 3 weeks if there is a decreased amniotic fluid volume. There is no hurry. So the first and foremost thing is that we should describe our limitation. If somehow my patient is having a flight and they are coming to me at 17 weeks and they are asking for a fetal echocardiography, okay, I will do it, but I will let them understand that I am not replacing the fetal echocardiography done at 24 weeks. They have to come again to me for 24 weeks. Only then I can achieve a better detection rate. Fetal position, if you are thinking that the fetal spine is up and you are not being able to see the face or the heart, tell them very clearly that you have to come again. Multiple gestations, the chances of defects are high in the monochorionic, and the missing of defects are also high. Make them understand, write down in your report. Oligohydramnios, there is always a limitation, so we have to write it down. Fibroids, anti-wall fibroid, you have a very poor window. Write it down, explain them in detail. Obesity, I will take one full slide, because obesity is something that is rampant in our population, particularly in the North India, and we are on the third number as far as world is concerned, as far as BMI is concerned. So here, not many people know that it is not the only limitation of the diagnosis. The risk of congenital anomalies are also high in these women. So you have to write down in your report that there is not only limitations of detection the congenital anomalies, rather than the risk of congenital anomalies are also high in these patients. Like in this paper published as late as 2023, they say that overall risk of congenital anomalies is 3 to 5%. This risk increases with the maternal obesity. Pregnant women with obesity are at high risk of multiple types of anomalies in various organ systems, including cardiovascular, renal, and neurological system. Several of these are associated with the dose-dependent risk, such as the risk is greater with increasing BMI. Along with the increased risk of anomalies, maternal obesity is also associated with the lower quality sonogram images and poor rates of completion of the anatomy scan at such initial attempt. So you have to very clearly write down these facts. If the patient wants to have literature, you should also give them literature about this. Secondly, and most importantly, you should take extra 2 minutes or 3 minutes before your mid-trimester scan. You should make them understand that this is screening of the congenital anomalies. This is not the ultimate thing, and you should describe the limitations, a general limitation and patient-specific limitation. That is what both the guideline, international guideline ISWOG and the national guideline Society of Fetal Medicine says, that you should describe this limitation in general and patient-specific as well, and you should put them into your record as well as reports. Now, what happens if the baby is born with the congenital defects? Then there should not be a blame attitude. There should not be any loose talks. Counsel with compassion. You should always counsel them with sympathy. Give adequate time in the counseling. There should not be in any hurry. Describe them your limitation. Describe them your reports also. Go with the search engine with them in your computer. Show them what the literature says and what are the detection rate. Then show them positive side also, like the rehabilitation, correction, and the surgery. Discuss and involve with ultrasonologist if you are a clinician, fetal medicine specialist, geneticist, pediatric surgeon, cardiologist if needed. The first slide I shown you that the compensation 1.25 crore. At that time only, we and Sharda ma'am have decided to do something for this cause. And we are working relentlessly for last few years for this position statement, and hopefully we will soon this statement will see the day, and we will come out for an India-specific position statement for the detection rate of congenital. Thank you so much for all.